Hey folks, please forgive the hat. I'm recording this during Shark Week, so um, kind of in the spirit of things. All right, so this is the last section of blood vessels and cardiovascular. I actually didn't realize there was anything in here but pictures, illustrations, until I went and read them. Oh no, there's good, useful information. So there, slides 1 through around 50, we're going to go over. And then we're going to jump to the very end, blood vessel development. But the stuff between around slide 50 and around slide 80, that's just picture after picture after picture that you have to go and learn the names of all the vessels. I'm not going to be filming that and going over that. You have the book, you can do it on your own. You have the PowerPoints, you can do it on your own. All right, so with that, let's jump in and go through this as quick as we can here. So perfusion is providing oxygen, providing blood to the body tissues. So when we perfuse something, we're delivering oxygen nutrients to it. We're taking waste and carbon dioxide away from it. At the lungs, we're going to do gas exchange. Obviously, this AP2, there's a whole section on respiratory system, so we'll be doing that in depth later. Absorption of nutrients from the digestive tract, we'll be talking a little bit about that when we do digestion. Urine formation in the kidneys. I guess basically what I'm saying is the blood is in contact with every other system. Anyway, and we have to match the amount of blood we're sending to the proper function for that organ at the moment. For instance, a stomach needs a lot more blood right after eating than it does when you haven't eaten in a while. All right, moving on. So the rate of blood flow to an organ, there are extrinsic factors, ones that are outside of the blood, outside the cardiovascular system, and there are intrinsic ones that are controlled by the cardiovascular system. So extrinsic controls, we have the nervous system and we have hormones. Nervous system, those are more direct signals. Hormones, you send a signal to the whole body, and any cell that has a target can respond. It's not just one type of cell in one spot usually. Anyway, both of those are going to act on, when I say both of those, I mean nervous system or hormones, will act on the smooth muscle in the tunica media of the arterioles, and that will cause it to either vasoconstrict or vasodilate. Moving on. So the intrinsic controls, blood flow is adjusted locally for a specific tissue. I think I told you before that local capillaries will be closed a lot of the time, and then the tissue is like, oh, we need oxygen, and the capillaries will open for a nice spurt of oxygenated blood. And yeah, organs can control their blood flow by controlling the resistance of their own arterioles. Now, you remember resistance, there are a couple different things that cause resistance. One is the viscosity of the blood. The organs are not affecting that. Another one is the length of the vessel. They're not affecting that. And the third one is the diameter of the vessel. That's what's being affected when the organs regulate their own blood flow. Organs can send signals to say vasoconstrict or vasodilate. Moving on. Okay, so intrinsic controls, those are controls that are happening that are an organ does itself, blood does itself, and those we would say we have local control or auto regulation. Extrinsic, we're sending a signal from the outside from some other organ, that would be nerves or hormones. Where do both of these happen? Stroke volume of the heart can be controlled by both. Arterial or diameter can be controlled by both. The glomerular filtration in the kidneys. So we'll talk more about that when we get to kidneys. But yeah, the amount of flow you have through those fenestrated capillaries in the glomerulus, yeah, that's something that can be controlled. Why? I didn't say it. Why? Because you have a afferent arteriole delivering blood to the glomerulus and an efferent arteriole draining blood away from the glomerulus. Anyway, and you can control the diameter of those arterioles. All right, so example, we could redistribute blood during exercise. When we're at rest, our muscles get 20% of the blood. When we exercise, they could get 70% of the blood. Here's a pretty picture showing the difference between the distribution at rest and the distribution when we are excited, when we are exercising or running from horrible things, whatever. What I want to point out is that kidneys and abdominal organs get a lot of blood when we're at rest, and kidneys and abdominal organs get very little whenever we're in a fight or flight situation. Um, the brain gets the same about all the time. But the heart, the skeletal muscles, the skin, they're going to get a much larger amount of O2 when we are running or under stress or whatever, doing a sport. Okay, so autoregulation, the local intrinsic controls that control how much blood is going to an area. You could have reactive hyperemia, meaning you increase flow of blood to that area because of what's happening, because of what the organs is exposed to. The two types of controls, the two types of intrinsic controls for this autoregulation, we can have metabolic or myogenic. I want you to notice myogenic means generated by muscle. All right, so let's move on. Metabolic controls, those increase metabolic activities as you're exercising, say the muscles, they're running out of oxygen, and there might be increasing levels of hydrogen or potassium or adenosine, prostaglandins. You have changed local chemicals in the tissue that way. And what does this do? How does the body compensate? It could directly relax the arterioles and relax the precapillary sphincters, so you have nice oxygenated blood delivered to the site. It could cause you to release nitric oxide, which is a chemical that causes vasodilation, even more blood delivered than you would expect because you just vasodilated. All right. The other thing, other than intrinsic controls that we have, are the extrinsic controls. You already know we're talking about blood and hormones. Well, some of the other things, sorry, I said blood and hormones, nerve signals, hormones, but also nitric oxide, endothelians, um, and inflammatories. Anything that's an inflammatory chemical, part of the inflammation, the part that gives it that red, inflamed look, is because you're delivering more blood there because you vasodilated the vessels. All right. So those are the metabolic controls. Let's now do the myogenic controls. In myogenic control, the smooth muscle in the arteriole, it can respond to a change in mean arterial pressure to make sure you keep blood delivered to the organ. One thing you can do is passive stretch. If you have increased stretching of a blood vessel in an organ more than normal, the smooth vessel will respond by constricting, decreasing blood flow from the tissue. If you have reduced stretch, Was it reduced? Yeah, if you have reduced stretch, you can decrease mean arterial pressure. The smooth muscle will respond by dilating, causing the increased blood flow from the tissue. Great. All right, long-term autoregulation. This is more than responding to a temporary thing. This occurs when short-term autoregulation can't meet the needs that we have. Whether that's it says nutrient, but I'm thinking nutrient and oxygen both. Anyway, long-term autoregulation, you can change how the body works. What the body uses is the baseline that it operates from, that it sends things. But in order to do that, you're going to have to change your target organisms. Sorry, you're going to have to change your target organs and how they respond to blood, how they ask for blood. It might take weeks, it might take months. You could also grow new blood vessels. We call that angiogenesis, or also angiogenesis, expanding the ones that you have. Let's see. Common in the heart when coronary artery is occluded, and throughout the body, it's a people in high altitude. Yeah. Okay, let's move on. All right, so here we have a nice pretty chart. It doesn't say which one it is, but metabolic, neural, okay, looking at this, I think the what we were just talking about, the vasodilators, vasoconstrictors, that part of this this diagram, this center portion, both the center top and center bottom, are things I'd like you to know. The other stuff may not be as important. Basically, let me word that another way. Angiotensin, antidiuretic hormone, epinephrine, norepinephrine. Where did it go? There we go. AMP. Those are things you're going to see them again anyway when we do the endocrine system. Might as well learn them now. But I'm probably going to write a couple questions based on them anyway. But if you don't learn them now and you don't learn them later on when I use them, then you'll have lost points on the same questions multiple times. Bad form. Okay, going on. So blood flow to special areas. The skeletal muscle has blood flow, obviously. How much will depend on the amount of activity you're using and the type of fiber. The type of muscle fiber. At rest, myogenic and neural mechanisms are going to predominate. They're going to maintain flow at around a liter a minute. Active and excessive exercise will, where was that? So at rest, myogenic and neural controls will predominate and maintain flow. Yeah. Active and exercise hyperemia during muscle activity, blood flow will increase for direct proportion to the body. Local control overrides sympathetic vasoneuroconstriction, and it can let flow grow again, let flow increase again. All right, hold on a second. Okay, so if you are active or exercising, you're going to increase the blood flow to the muscles. That makes perfect sense. Local controls, you have sympathetic vagus saying, oh, vasoconstrict. And because the organs need oxygen, need blood flow, they're going to override that and say, yeah, forget about that. Just give me what I need. And it can go up 10 times. I mean, huge amount. All right. So here we have an exercising skeletal muscle. I'm going to say probably a biceps. Anyway, but yeah, we got a exercising skeletal muscle, and the amount of oxygen level is going down. The carbon dioxide is going up because we're doing a lot of respiration. The hydrogen ions are going up. Why? Because that means it's getting acidic, and that means if we're running out of oxygen, if oxygen goes down too much, then lactic acid is going to go up. Okay. Um, what is going to happen as a response under this local control? Vasodilation of the arterioles, overrides the sympathetic. That means you have blood rushing in. So yay, just what we were talking about. Okay, blood flow in special areas. The brain has to have a constant flow of blood. Neurons do not handle low oxygen levels. The flow of blood to the brain is 750 milliliters per minute. That tends to be true whether we're at rest or we're doing things rapidly. What we have to do is maintain that. We can't let it go super high because it's got really delicate vessels. We could blow them out. So our goal is to keep the blood flow the same. Yeah, well, sorry, it just crossed my head, but I really don't care. This is a human anatomy class. In some animals, that works very differently, but we'll talk about that if you want outside of class. All right, but so metabolic controls. If the pH is dropping, again, you're putting out hydrogen ions because you're running out of oxygen, or the CO2 levels are coming up. Either one will cause vasodilation, so you open up the vessel and allow more blood to flow through. Um, but if you get very, very high CO2 levels, these autoregulatory things don't work well. All right, so what are the controls in the brain? Myogenic controls, funny name because we're not dealing with muscle, but run with it. Decreased mean arterial pressure will cause the vessels to dilate. Increased mean arterial pressure causes the vessels to constrict. We're trying to keep the flow exactly the same regardless, because the brain is vulnerable to extreme changes in the systemic pressure. If you get less than 60 millimeters of mercury, you're going to faint. If you get above 160, you got fluid squeezing out and of the vessels, oozing out of the vessels and squeezing on the brain. Not good, not good. So, got to keep it about 750. All right, skin is an area of special control. That's because the skin is involved in body temperature regulation. Also, a blood reservoir. You could store huge amounts of blood there. Remember, I told you you can't open up all the blood vessels at once, especially the skin. We don't have enough blood in the body to do that. So, blood flowing through the skin, we can use autoregulation to control how much oxygen we need. That means that we'll open up a capillary bed for a little brief spurt of the good stuff with the nice oxygen. And then we'll close it down again until we need it. But if we overheat, we're going to send more blood to the surface so we can radiate heat off. In fact, then we're going to sweat on top of it so that evaporates and cools it off even more. So if you have evaporating sweat on top of the skin and radiating blood vessels right below, you're going to draw a lot of heat off. You're going to cool down that blood. Anyway, moving on. So blood flow through the venous plexuses below the skin helps regulate body temperature. It can vary from 50 milliliters per minute, just barely trickling by, to 2,500 milliliters per minute, depending on body temperature. When we get hot, we try to cool off. The flow is controlled by sympathetic nervous system. That makes sense because sympathetic, remember, fight or flight, you're going to get overheated whenever that's happening, when you're fighting or running, or so you will compensate by, hey, we're going to be doing some vigorous things. Let's start sending blood to the surface to cool it off. These reflexes are initiated by temperature sensors and by the central nervous system. When the temperature rises, the hypothalamus is going to reduce vasomotor stimulation of the skin cells, skin vessels. What that means, the vasomotor stimulation is causing vasoconstriction. We're going to say, shut up. So then the vessels will relax and dilate. The warm blood rushes into the capillary beds, heat radiates from the skin. You've heard this already. As the temperature decreases, the blood will be shunted deeper to more vital organs. Superficial skin vessels constrict really tight. Blood could be trapped in the vessels. This is what causes your cheeks to be rosy colored in the cold. Okay. Lungs. The pulmonary circuit is different. It's a short pathway. And the vessels are slightly different shaped. Remember, the arteries are carrying blood away from the heart. Always true. That means the arteries are carrying low oxygen blood. And in the case of the pulmonary circuit, in the case of the pulmonary circuit, they're carrying low oxygen blood. And they tend to be shaped a little more like veins. They're thin wall. They have big hole in the middle, big lumen. I should say big space in the middle. Anyway, the lower resistance, lower pressure than in the systemic circuit. This makes sense because they're shorter, but also because they're bigger diameter. And so in the systemic, 120/80 would be a nice average blood pressure. This is the hypertension, it's worse, but in the pulmonary system, 24/10, a lot lower. Why? Well, it's real important we get blood to flow through the lungs real nice so we can oxygenate it. So autoregulatory mechanisms are opposite of what you would expect. Low oxygen causes vasoconstriction. High levels promote vasodilation. What? Well, actually, it makes perfect sense. Suppose someone's been smoking and they've got a damaged part of their lung, and you have difficulty transferring oxygen across the wall of that lung, that part of the lung. You don't want to vasodilate and send all the blood there. If it's low oxygen levels, you don't want blood to go there, so you vasoconstrict. Remember, most of the body, like say your quadriceps muscles, and we're low O2. Yeah, we'll open up the blood vessels and deliver lots of blood, so there's lots of oxygen. At the lungs, you do the opposite. You vasodilate to areas, the vessels going to areas that have lots of oxygen to give, and you vasoconstrict the blood vessels that are going to areas of the lung that don't have a lot of oxygen to give or aren't able to give a lot of oxygen. All right, in the heart, this is weird. The aorta being stretchy is what pumps blood through the coronary arteries. All right, blood flow through the heart influenced by aortic pressures and ventricular pumping. Yeah, totally true. When the ventricle is squeezing hard, the coronary vessels get kinked. They get twisted up. Blood doesn't flow. But heart's okay because myoglobin, the muscle version of hemoglobin, is storing the oxygen. But when the ventricles relax, there are no kinks in those coronary arteries, and the aorta is now, remember, when the blood went through during ventricle systole, the aorta goes, stretches. Well, the ventricle is now trying to return to its normal size, and we have unkinked the coronary arteries that are right by the semilunar valve. What that means is that some of the blood that you're squeezing will get pushed, instead of over the aortic arch, it'll get pushed through the coronary arteries, the left and the right coronary arteries, which then, of course, will feed things like the marginal, like the left anterior descending, blah, blah, blah. The circumflex humeral, you got it. Um, at rest, coronary blood flow is probably 250 milliliters per minute, and the control is probably myogenic. During exercise, those vessels dilate because the heart is working harder, so it's needing more oxygen, so the heart needs more blood. Those vessels dilate, get 3 or 4 times as big as they were, and cardiac muscle cells are greedy for oxygen. They use like 65% of what is delivered. Other cells in the body, they're only capable of using about a quarter of what's delivered. But the heart, really good at using oxygen because it has high oxygen demands. And increasing coronary flow is the only way that we can give more blood to the heart. All right, so now we're going to talk about capillary exchange. This is where we're going to talk about what I mentioned before with hydrostatic pressure and osmotic pressure. It's easy to remember the H in hydrostatic pressure is towards the end that is close to the heart. H, heart, hydrostatic, close together. The other end, so hydrostatic pressure is at the heart end of the capillary bed. At the other end, we have osmotic pressure. Why? Because as we ooze out squirt out all of the fluid, the fluid in the blood with the oxygen, with the nutrients, the plasma proteins, the things like albumin, the cells, the formed elements, those are kept inside the capillary. That means that as it loses fluid, the inside of the capillary gets more concentrated, more concentrated, more concentrated, more concentrated, more concentrated. By the time you get down the venule end of that capillary, it's pretty concentrated. And because water wants to dilute stuff, we have the water coming back into the capillary. Osmotic pressure is what we call that tendency to draw water back into the capillary. So hydrostatic pressure on the heart end, osmotic pressure on the venule end. If you think about it, you could also say they're alphabetical, like artery comes before vein, and hydrostatic comes before osmotic. So anyway, moving on. So okay, I guess we're going to talk about that later. I thought that was right next, but we'll get to it. Velocity of blood flow. Blood flows through the systemic system, and the rate at which it moves changes depending on where it is. It's fastest flowing in the aorta, it's slowest in the capillaries, it speeds up again in the veins. You might say, how? And you say, whoa, well, it's like a river. If you take a river and you have these wide banks that are far apart, it's a nice big lazy river. If you take it through a little narrow canyon, and that water is going to speed up. Okay. Same thing happening here. So why is a teeny tiny capillary where the blood cells have to line up single file to go through? Why is that not moving at super speed? Because again, it's just like a river. Say we have a river that's flowing, and then we have it branch out into 20 million little streams, so that the total area the river's going through, each stream is little, but all these parallel streams lined up. Okay, I can do it with my hand here. We have a river flowing into a delta system where you have many, 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 many streams. Look how the many streams are a much wider area than the river back here. Well, when you go through the many streams, you're going to slow down. If you went through a single stream, it would speed up. But the total cross-sectional area here is much larger than it is back here. What that means is that you will slow down as you trickle through all the little things. Why is it good to have the blood slow down as it trickles through all the many little capillaries? Because it delivers you more, it gives you more time to do the gas exchange, to do the nutrient exchange, to pick up the waste. All right, moving on. So here we have the pictures, and you can see the total area of the capillaries. There's way more area in the capillaries than there is in the aorta, the most giant vessel there is in the body, just because you have so many capillaries. What that means, because you have a lot more area, is that it goes slower, 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 slower. Here, the blood is barely trickling along. Then as we gather up into the venules and the veins, we're going to speed up a little bit, but we're never going to be at the speed we are when we're coming out of the heart, because the heart's right by the aorta, the big arteries, they're right by the pump, they're right by the heart. So of course they're going to always be faster than this, but that doesn't mean that there's not a big shift in speed and velocity caused by the cross-sectional area. Moving on. Vasomotion. This is the intermittent flow through capillaries. You've heard me say this many times already. Precapillary sphincters can open and close. What that means is that we are going to close off capillary beds until they, where's a pretty picture? Well, it's not going to give us one. We're going to close off capillary beds until the tissues say, hey, we really need some oxygen. And then we'll open up those precapillary sphincters, send a squirt of nice oxygenated blood in there so the tissues can have some oxygen, and then we shut it down until they need it again. So diffusion, if you remember, when things diffuse, they're moving down a gradient. That's a fancy way of saying they're going from an area where there's a lot of what they are to an area where there's very little. And this means that if we have an area with lots of oxygen up here and an area with very little, move that out so you can see. I've been talking with my hands, they're not even showing up on the screen. So an area with lots of oxygen here, area with very little oxygen here, the oxygen will diffuse, it will move from the area of high concentration towards the area of low concentration. Same thing, in the tissues, you've been building up lots of waste, lots of carbon dioxide. So you have high levels of carbon dioxide down here, very little carbon dioxide there. It will diffuse towards, it'll spread out, move from the area of high carbon dioxide concentration to an area of low concentration, meaning carbon dioxide wants to go into the blood. All right, so many molecules pass down a diffusion gradient. Great. There are 4 different ways you can get across a capillary, and we're the wall of a capillary, and we're going to go over all 4. You could diffuse right through the membranes of the endothelium. This works for like respiratory gases. They dissolve well in lipids, and that means they can cross a phospholipid bilayer, a cell membrane, better than other things. Water soluble solutes, we're talking about things like dissolved sodium, dissolved calcium. They can pass through clefts. All right. Bigger things are going to need a hole. They're going to need a fenestration to go through. It's still going to be a water-soluble solute, but it's going to be a bigger water-soluble solute. And then we could have active transport. Active transport, the A in active reminds you of ATP. Not that it's always ATP, but it's the same idea. The cell is having to spend energy to move things across the wall, across the membrane. And in order to do that, it might be making a protein molecule and embedding it in the membrane. It might be growing a vesicle that goes out and grabs something, like white blood cell looking for bacteria. Oh, that bacteria there, I will eat it. They grow and make a vesicle that when they pull it in, yeah. That kind of activity takes some energy. So it's active. Active takes energy. All right. So quick review, pinocytosis. Pinot means to drink. Think like the wine Pinot Noir. Hold on a second. And pause. Okay, so we were talking about how you do exchange across the wall of a capillary. You can pass through the little windows, the little fenestrations. Like I said, that would be for bigger water-soluble things. And big molecules like proteins, you get across by making vesicles, transport vesicles. The pinocytotic here is just cyto for cell, pinot for drink, like Pinot Grigio, Pinot Noir. So pinocytosis, your cell is taking in liquids and things in the liquid. But yeah, the whole point is you might have to grow a transport vesicle. All right, moving on. All right, pretty picture showing what fenestrations look like, what the clefts look like. Great. Oh, and there's a pinocytotic vesicles being pulled in. So yeah, you've got all three methods there. Oh, I guess they're it's nice and big in case if we didn't get it before, but we got it before. So all right, fluid movements, bulk movements. All right, so here's where we're finally talking the hydrostatic and the osmotic pressure. You've heard this stuff before. Fluid is forced out of the capillaries at the arterial end, and most of it returns to the blood at the venous end. You already know that the extra stuff that's brought in is lymphatic system. Anything that you can't bring back at the venous end, you're going to bring back with the lymphatic system to avoid that whole puffy edema thing. Anyway, this balance of fluid forced out, fluid brought in, extremely important determining relative fluid volumes in blood and interstitial fluid. And the edema I just mentioned is when your interstitial fluid is filling up with fluid that's not being drained properly. Bulk fluid flow across the capillary walls causes continuous mixing of fluid between the plasma and the interstitial fluid. They're talking about the blood plasma, and the interstitial fluid maintains the interstitial environment. Direction and amount of flow depends on two forces: hydrostatic pressure, colloid osmotic pressure. I already told you that hydrostatic pressure, the H should remind you of heart. This is the this is the pressure generated by the heart, okay? And the osmotic pressure, that's what happens when water wants to dilute stuff. Water wants to get back into the blood because the blood is getting kind of thick and concentrated. As you leave behind all the albumins and the formed elements, it's getting concentrated, and water wants to dilute that, so it comes back in. That's the mechanism. All right, let's go find the math. Hydrostatic pressure forces fluid. It's the force exerted by fluid pressing on the wall. There are two types. There's capillary hydrostatic pressure. That is the pressure that is that's pushing against the capillary. Greater at the arterial end than at the venual end. Capillary hydrostatic pressure is the one I've been talking about all along. There is interstitial fluid hydrostatic pressure. That's the pressure of the fluid around the capillary. You know, if you push on the wall of the capillary, the fluid that's outside is going to push back. But as long as you have higher pressure here and you have all of those clefts and fenestrations, you're going to be forcing fluid out. All right. So capillary colloid osmotic pressure, the sucking pressure, non-diffusible plasma proteins, mostly albumin, by the way, are pulling the water back in. That's the main plasma protein. It does a lot of blood buffering, but it also is too big to fit out of a capillary unless the capillary is damaged. So it brings a lot of stuff back. Anyway, the osmotic pressure there is probably around 26 millimeters of mercury. The interstitial fluid colloid osmotic pressure, inconsequential because there's so little protein content, very, very little. All right, so that's what sucks fluid back in. So the net hydrostatic osmotic pressure, net filtration pressure. What we're talking about here is stuff going across the wall of a capillary. You're going to hear net filtration pressure again when we talk kidneys, because kidney glomerulus stuff. But net filtration pressure comprises all the forces acting in the capillary bed. That is hydrostatic pressure trying to get out plus osmotic pressure. Sorry, hydrostatic pressure of the capillary versus plus the osmotic pressure of the interstitial fluid, which we just said is practically nothing, maybe 1 millimeter of mercury. Minus hydrostatic pressure of the interstitial fluid, it's always lower than the capillary, and osmotic pressure of the capillary, it's always higher than the interstitial fluid. So what we have here is high number, low number, minus low number, high number. So anyway, the net fluid flow out at the arterial end, that's filtration. Net fluid into at the venous end, that's reabsorption. So you've heard it many times already. There's probably a pretty picture coming up, but you're going to push the fluid out at the artery end, and then when you get closer to the venous end, you're going to start pulling the fluid back in. The excess interstitial fluid returned via the lymphatic system. Again, you've heard that. So there's a picture of it happening. Great. And this is talking about this is a nice illustration of what would happen in a U-shaped tube. But it's exactly what we said. It's easy to follow. All right, bulk flow of fluid across the capillary walls causes continuous mixing. That makes perfect sense. You can see that, just like we said, hydrostatic pressure in the capillary, big number. Hydrostatic pressure in the interstitial fluid pushing into the capillary, minor, very minor. You can see that osmotic pressure pulling into the capillary can be relatively big. Compare that to osmotic pressure to pull fluid into the interstitial, not much, not much. So your net filtration pressure, when you add and subtract these numbers according to that formula, in other words, know that formula, there's a slight flow out, 10 millimeters of mercury pressure, moving things out at the arterial end. All right, now at the at the other end, at the venous end, you can see that there is a overall net slight movement in. So just what we've been saying all along, you push fluid. Oh, sorry, let me go back and we'll say blah blah blah. Where was it? There we go. More fluid leaves at the arterial end than is returned at the venous end. And then at the venous end, more fluid returns than you have more coming in than going out at the venous end. All right. So now we talk about edema. Edema, that whole puffy joints thing. Either someone has too high of pressure, that could be caused by something like having super high blood pressure. But if you have too much pressure pushing fluid out of the capillaries, or difficulty pulling it back in, you're going to have fluid buildup in the interstitial fluid. And the only way to get rid of that, you can walk and use venous pumping, using lymphatic pumping, muscular pump on the venous and lymphatic system. That'll help. But the other thing, a lot of times they give you drugs, antidiuretics, to make you pee huge volumes to get rid of the excess fluid. Anyway, an increase in capillary hydrostatic pressure will accelerate fluid loss from the blood. That could be lousy valves, localized localized blockages in the blood vessels, congestive heart failure, high blood volume. All right. If you have an increase in the interstitial fluid pressure, say from the inflammation response, you could lose more things. The capillaries get more permeable from inflammation. That means that bigger things like proteins can leak across easier. This could cause a lot of fluid to be pulled into interstitial space. I don't like the way they worded that. I would say pushed into, but okay, whatever. If you have a decrease in capillary osmotic pressure, then you're not going to pull the fluid back in. Fancy way of saying, if the natural water wants to dilute stuff. If you don't have the blood concentrate enough at the venous end, it's not going to happen. This could happen because you have hypoproteinemia, meaning you have not enough protein in your blood. Remember, the albumin proteins are the main thing that creates that colloid osmotic pressure. So if you're low in protein, you got a problem there. Low levels of plasma proteins from malnutrition, liver disease, you're not making all the things that are normally in the blood, or glomerulonephritis, loss of plasma proteins from the kidneys. The glomerulus, the filter membrane in the kidneys, has inflammation, itis. All right, let's move on. So, edema, we already said you're not draining the interstitial fluid well. It could be that the lymphatic vessels have been blocked, like by disease, or you surgically remove them. Having too much interstitial fluid in subcutaneous tissues causes pitting edema. I know there's a serious picture coming up. Let's do it right there. So if you squeeze, it actually leaves a dent that slowly comes back. That's how much the tissues are puffed up. Edema can impair tissue function as a result of increased distance for diffusion of gases and nutrients and waste between cells. What we're saying is if you got more fluid in the tissue, it's a greater distance for nutrients to travel to cells, oxygen to travel to cells, or waste to travel away from cells back to the blood. That can be a problem. If it's a slow fluid loss, you can compensate with your kidneys. Rapid onset could be a big deal. Okay. We're going to continue just a little bit into slides 45 and 50. But after 50, it's illustration, illustration, illustration. We're going to jump from there down to 80. You can teach yourself the illustrations. I don't need to go over each one. For each illustration, what you're doing is comparing them to the lists, which I already gave you, of vessels that you need to know, and then you will memorize them. All right, so there are two main circulations. The pulmonary circulation, that's right side of the heart to the lungs, and then back to the left side of the heart. And then there's systemic circulation, that's left side of the heart through the entire body, and then back to the right side of the heart. So the main systemic circuit artery, the big one, it's the aorta. Blood returning to the heart comes through terminal vein, superior, inferior vena cava, and then off of the heart, the coronary sinuses. All right, there's the pretty stylized schematic, but it's nice. It works well. It explains it well. That's great. Here's a more realistic drawing. And so now let's talk about where arteries are located. Arteries tend to be deep inside the body. Veins could be deep, but you could have them superficial as well. Basically, it makes sense if you think about arteries being higher pressure, put them a little deeper so they're a little harder to damage. Deep veins tend to have it says arteries run deep, only but veins run deep or superficial. We just said that. Deep veins usually have the same name as the artery that they're with. Superficial names, superficial veins have rotten names that may or may not correspond. I already told you that on the heart, all the veins have horrible names. Anyway, moving on. Veins have more anastomoses. That's because they're lower pressure and it's easier to hook them together without leakages during development. It says veins can have more than one name. Think of them as like a highway. Making venous pathways harder to follow. The brain and the digestive system have their own venous drainage systems. The brain uses the dural venous sinuses. We're talking about sinuses, spaces, and the surrounding the brain. You may remember from AP1, we have the dura mater, the pia mater, Well, I should say the it's not tunica. It's the pia mater, dura mater, and between them the arachnoid mater. It took me a second. All right, and the venous sinuses are between layers. So the venous system of the digestive system drains into the hepatic portal vein, which perfuses through the liver before returning to the heart. This makes sense. What if you eat or drink something bad for you? Send it through the liver first to have it check, to have it detoxify before you send those chemicals out to be used in the rest of the body. You got to make sure they're safe. That's one of the things you do run through the liver. All right, and there is a nice drawing of the same. What's happening to head and upper limbs, what's happening in the heart, what's happening in the capillary beds. Oh, mediastinal structure. All right, so they're talking about the bronchi and stuff like that, the trachea. All right, then below the diaphragm, obviously, you have what's happening to all the viscera, all the organs, and then separately from that, what's happening to the gonads. All right, so let's move on. Diagrams 22. Yeah. Diagrams of oxygen-rich blood are shown in red, oxygen-poor blood shown in blue. Schematic flow charts, pipe diagrams show vessels. They're closer to the surface in brighter colors, and ones that are deeper in dark colors. How do you memorize blood vessels? Because you're about to memorize a whole ton of blood vessels. The name of the vessel usually reflects the body region, or the organ that you're serving, or the bone that you're following. So, yay. And arteries and veins tend to run side by side. A lot of places it's arteries, veins, and nerves run side by side. The systemic vessels may not be symmetrical between the left and the right side of the body. They tend to be on the head. They tend to be on the upper limbs. But, not all places. Not all places. So, let's see. Yeah, the trunk, they're meaning the thorax, the abdomen. They're asymmetrical, unpaired. Okay, and now we're in these huge, memorize all the things. You have a list. You have 3 pages that have lists, one for coronary vessels to know, one for arteries to know, one for veins to know. You've got to memorize them. You got to go through these illustrations. And with that in mind, I'm going to jump to right here, and then we'll wrap up. Okay, so now we're going to talk about the developmental part of blood vessels. The endothelial lining comes from mesoderm cells. You might remember that we have ectoderm, which is the outside, and we have endoderm, which is the inside. And in the middle space of a developing embryo, that would be mesoderm. Okay, meso meaning the middle, so it's the layer in the middle, and that's the stuff that some of that will become blood vessels. You get blood islands forming from these vascular tubes. Vascular endothelial growth determines whether a vessel becomes an artery or a vein, the endothelial growth factor. And the heart will start pumping blood by about week 4. You have 2 fetal shunts that we've talked about before. The foramen ovale, which is a hole in the interatrial septa. It allows blood to go from the right atria into the left atria. Why? We're bypassing the lungs because we're not picking up oxygen there. So some of the blood just skips that. The other one, the ductus arteriosus, same function, bypassing the non-functional lungs, but it does it differently. What it does is, if you happen to do right atrium, so the process begins where blah, 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 blood enters the heart, through the tricuspid valve to the right ventricle, the pulmonary semilunar valve, pulmonary trunk, and then we're going to send the blood through this ductus arteriosus into the aorta and send it through the body. Okay. So ductus arteriosus is between pulmonary trunk and aorta. And as you get older, it shrivels, 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 shrink, 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 until it becomes, hey, that's odd. Can I have one? Sorry, yeah, you don't have it anymore as a vessel. It's just a shrunken, we'll change it from a duct, we'll rename it to the ligamentum arteriosum. It's like a ligament. There's just the connective tissue of the outside left. And the foramen ovale will change its name when we're born to a fossa ovale. It's a spot. It's no longer an opening. It's like a scar. All right. You also have, and we haven't talked about this yet, the ductus venosus, which will bypass the liver. So umbilical vein, umbilical arteries, they send blood to and from the placenta. And we have congenital vascular problems occasionally, but this vessel formation is for body growth, wound healing, rebuild. Yeah, we've got that. This is the why are reasons to make blood vessels, in addition to what we were talking about before with the umbilical